Okay, well, welcome to this pharmacology review on treatments for smoking cessation. I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform their medical knowledge from not just knowing the what, but why. Knowing the why allows us to master the how, which is about the application to the patient. Like many addictions, smoking cessation requires a clear strategy that incorporates the appropriate use of treatments. Now, according to the CDC, approximately 28.8 million adults in the United States alone still smoke. Now, this is down from over 12% from 2021. Now, that's good, and it shows some progress being made, but we still have a lot of work to do. Okay, so why is it relevant to learn about treatments for smoking cessation? Well, it's not rocket science, guys. Smoking is associated with a large number of chronic medical conditions to include lung cancer, COPD, cardiovascular disease, diabetes and type 2, peripheral arterial disease, aneurysms, slow wound healing, and premature aging. Let's just keep adding to the list, right? When I see patients in the emergency department and they're there for some bad event, their common theme that I see over and over again is their history is positive for smoking. Now, we all need help to get through things that we sometimes just get addicted to. And up until half the patients try to quit, most of them won't succeed, right? So when we combine it with treatments that work, when we add cognitive behavioral therapy, it really does help with that abstinence rate. So that's why it matters, and we need to be purposeful with initiating the treatments in a patient-specific manner to guide them towards that success. All right, so there's different approaches. When we're talking to our patient, you really need them to be engaged. And we prefer it actually to be patient-led. That's where you're going to get the success. There is a personal investment in this process. And so we use two strategies known as the 5 A's and the 5 R's. Now, the 5 R's are really about kind of motivational interviewing for those who are not ready. The 5 A's are for those who are. So what are those 5 A's? We ask, we advise, assess, assist, and then we arrange for them to get the treatment. So the 5 A's, again, for people who are ready, that want to be a part of it. Those who are not ready but recognize that at some point they need to be. We need to reinforce the reasons to go ahead and take the plunge. Why is it relevant to stop? What are the risks if you don't? What are the rewards if you do? What are some of the common roadblocks that we all are going to experience? And then just being repetitive at that messaging. These two strategies, the 5 A's and the 5 R's, when we're purposeful, can be very useful at helping our patients arrive to a successful beginning and hopefully to a higher rate of abstinence. All right, I like to throw in a little bit of trivia, but it's important because you're assessing not only does your patient want to quit, but how much are they smoking? Because how much they smoke per day impacts some of the drug therapy treatment options that we use and how we use them, especially nicotine replacement therapy. So how many cigarettes are in a pack, in one pack? Well, the answer is usually 20, okay? Now, some packs do contain 10 cigarettes. Some even go up to as high as 25, but the average for most packs of cigarettes is 20 cigarettes in one pack. So that's important to know. So when you study their history and you look at their pack year history or how many packs per day, we need to put that in the context of the number of cigarettes based on that product. So now we need to talk about what treatment options exist for smoking cessation. All right. Well, I like to use tables. And they've always helped me to study, wrap my mind around things. Why do I pick one drug over another drug? What are the pros and cons? What guides the decision? Why do I see such variation in clinical practice? And some of that is just preference, experience, access to care, costs, side effects. All of those things drive that. So this is a large slide, got a lot of information on it. Probably hard to read. So I'm going to zoom in to each section. So there's 3 main treatment options here that are considered first-line treatments. That is Bupropion, nicotine replacement therapy itself, and Varenicline, also known historically as Chantix. So let's break them down individually and zoom in a little closer so you can see it. All of these tables are available at thisiswhy.health. We offer free accounts for you to be able to access collections, playlists, tools like this. So please check it out and feel free to go there if you need to access these for your own personal use and study. All right, so what about Bupropion? Remember, that's one of our atypical antidepressants. What I've tried to do with these tables is keep their orientation, but just make it bigger, like we've zoomed in only on that treatment. So up here we have the mechanism of action, and just as a reminder, since it is an atypical antidepressant, it affects the reuptake of both norepinephrine and dopamine in that synaptic cleft. Okay, that's a little bit mimicking what nicotine's effect is in the body, the end result. Okay, now we know dopamine kind of turns on that reward pathway, and this is a little bit where addictive things can come into play, and so that's why modulating the activity of that can sometimes be helpful and relevant. Now we know it's an atypical antidepressant, but we're using it for smoking cessation. Yes. So there are different formulations, the sustained release and extended release, and there's an immediate release. And so that's nice to have those options, but the original formulation was known as Zyban, not Wellbutrin, okay? Those are splitting hairs, but it's the way it was studied and the way it was approved, just to be fair. All right, so the next thing that we see are 3 columns. On the far left, we see the advantages of why we would pick that drug in this situation. In the middle column is the disadvantages. Why would we try to avoid it potentially, or what are its issues, because no drug's perfect, is it? And then lastly, over here at the end on the right are some of the just subtle clinical pearls. Let's talk briefly about some of the advantages first. Well, it's well established. It's been around for decades. I mean, I remember when I was in school, it was one of the treatment options that we used along with cognitive behavioral therapy. There are benefits if patients have underlying depression or if they're overweight. So this can cause a little bit of weight loss. I mean, it's a little bit more stimulating. If patients are also having experienced SSRI-associated sexual dysfunction, this drug switch can be helpful. If they need to quit smoking at the same time, all of that can be done with one treatment, okay? Disadvantages, the risk of seizures, especially at higher doses, or if someone uses it inappropriately or has an intentional overdose. Typically, that risk goes up after 450 milligrams per day, but it does lower the seizure threshold. Any drug that increases norepinephrine will lower the seizure threshold. So we got to be very careful of that in patients with uncontrolled seizure disorder, epilepsy. This is probably not the best option. And then considerations for dose and renal adjustments is warranted. Now, what about some clinical pearls? You see here it says begin 1 to 2 weeks before your quit date. Okay, so remember, we've gone through the 5 A's and they've determined a quit date. So we get everything ready, we're on their team, we're on their side, and we know what day that's going to happen. They can start to use this drug before they quit. And that's important because that's not the case for some other treatments. Okay? Now, generally, we have them stop smoking during the 2nd week of treatment. Okay, so that's kind of curbs some of those cravings. We're stimulating that reward pathway. We're treating some underlying depression. And hopefully we turn them that corner, make it a little bit easier for them to overcome that. Like I said, we have a number of different dosage options. You have to dose it appropriately based on the formulation. And then, you know, when you think about stopping medicines like antidepressants, typically we kind of consider a taper or a gradual. In this case, we don't have to worry about it. There's no rebound issues. They're either going to stop smoking or they're not. Okay? All right, so that's bupropion, our atypical antidepressant. Now let's go on to nicotine replacement therapy, also commonly abbreviated as NRT. Well, nicotine is just an agonist, okay, its mechanism, to the central nicotinic cholinergic receptors, and it mimics nicotine essentially. So it has that stimulant effect at low doses and reward effects at higher doses. Okay, that's its mechanism. Advantages: it is a first-line treatment option recommended by multiple guidelines. There's a lot of dosage formulations. We're going to talk about that. Gum, lozenges, like in nasal sprays, patches, all these things. We have a number of different things that we can use to fit the patient's lifestyle and needs. That's excellent, right? It can be safely used in patients even with cardiovascular disease, as long as it's not a recent one, right? So we can do it, you just gotta be careful, because quite honestly, smoking isn't helping them either. So at some point, we need to stop. You can add nicotine replacement therapy to Varenicline and Bupropion if they're having inadequate response, okay? And then lastly, it is an option if you are trying to get the patient and they're pregnant to stop while they're during their pregnancy. It is an option. Again, they're going to smoke, they're getting nicotine plus all this other junk. So you know, try. It's certainly a reasonable option. Now the disadvantage is you cannot overlap. All right, you should and you must stop smoking while you're also using these replacement therapies. So you begin on the quit date, not before. So you heard me with bupropion, you have about 2 weeks, right? Varenicline, you'll see that as well. Nortriptyline, which is an alternative, clonidine, which is an alternative. You can smoke on those drugs and not cause a problem, but we don't want to be smoking and using nicotine replacement therapy at the same time in patients, okay? So the way we dose it, the way we use it is influenced by the dosage formulation you're using, and then again goes back to their history. How many cigarettes are they smoking per day, right? So if they tell you a half a pack, that's about 10 cigarettes, right? Okay, so now we'll move on to Varenicline, and we see that the mechanism here is that it's a partial nicotinic receptor agonist. So it's basically working to prevent the nicotinic stimulation of the mesolimbic dopaminergic activity within this disorder. So very unique mechanism. Now, some of the advantages is very similar to nicotine replacement therapy. It's recommended by the guidelines. It is also something that you can use while you're still smoking. So you don't have to stop day one like nicotine replacement therapy. You have up to 4 weeks. So it's very flexible overall. From a tolerability standpoint, there is some dose-dependent nausea, maybe some sleep disturbances, and then historically there was concern about neuropsychiatric events. And there was a warning in the product package insert for a while about it, but the Eagles trial, published in 2016, helped to remove that. There is some controversy around it. Doesn't mean that there's absolutely no problems with it. It also doesn't mean that you should think of it as, you know, the worst thing. You just find a balance. Just all drugs have side effects, all drugs have issues. You talk to the patient, you create shared decision making. They understand the history, the rules, because if they go out on the internet and start reading about it, then they're gonna read stuff that's outside of the context. So, but keep that in mind, that there have been cases of neuropsychiatric events. All right, now we're going to move on to the alternative options. That's your nortriptyline and your clonidine. So nortriptyline being your tricyclic antidepressant. Okay, so it works on the presynaptic reuptake of norepinephrine and serotonin. And so this may help with anxiety and stress. It helps to facilitate smoking cessation by helping to reduce some of the withdrawal symptoms, and also anticholinergic effects may reduce some of the taste and desire of smoking, okay? So some of the advantages, if you have, just kind of like bupropion, if you have a concomitant depressive disorder, it can be helpful. If you have a coexisting neuropathic pain disorder, it can again be helpful so that you're hitting this, because what if some people smoke? You know, they need something to feed them, something to distract them, something to make something else go away. Same reason why sometimes people drink. And so think about your patient's comorbidities, their pain points, and if you can certainly intervene by using a drug that hits multiple things, I mean, why not? Now again, this is alternative, so this is not a first-line option. You want to achieve the greatest chance for success, so you should really be more strongly considering one of the first-line options that we just discussed. Okay? Now, obviously with this drug class, it can have more side effects. We know that TCAs have that side effect profile that makes them less desirable. They're no longer first-line options for depression. Okay? Part of the reasons for that are their antihistaminic properties, their anticholinergic properties, but also at high doses, they can inhibit the cardiac sodium channels that can lead to QRS widening, that lead to QT prolongation. Those sodium channels are also in their brain. And again, if in a high concentration situation, especially an intentional overdose, this can be life-threatening and deadly, okay? Now, you can also smoke while being on these, and you don't have to worry about the slow taper and issues with like you do with depression if you were using it for that reason. Now moving on to the last alternative option is clonidine. This is one of our centrally acting alpha-2 agonists. So it binds to the presynaptic terminal and it decreases the release of norepinephrine and some of the other neurotransmitters. This has been shown to help maybe reduce some of the cravings, the anxiety, some of the symptoms of withdrawal. We also use this in other conditions, which we'll talk about here in a minute. So if patients have underlying high blood pressure, it can be helpful. Not the big motivation, but it can certainly help blood pressure. But eventually you're going to stop. Okay? So while you can smoke on this drug, okay, like Bupropion and Varenicline as well, you can smoke. You just want to be careful because once you stop clonidine, you can have rebound hypertension and tachycardia. So it does require a taper to discontinue to avoid that extreme response. Now it does come in different dosage formulations. There is an oral and a transdermal. The transdermal patch at least allows for a full week of administration that can be more convenient. Okay, so what are some of the other reasons and things that we use clonidine for? It's not just hypertension and smoking cessation, but there's a formulation for ADHD, a long-acting formulation, opioid withdrawal. Okay, again, it helps avoid some of those sympathetic symptoms that occur when somebody's going withdrawal. And then lastly, vasomotor symptoms in menopause. So, you know, keep in mind, like your patients have a lot of things. Again, if you can tailor a drug to identify a way to help them on multiple levels, I think they'll not only appreciate it, but it can be a win-win and hopefully get you some greater success. All right, now we're going to step in and look a little bit on some of the general recommendations for mainly monitoring, evaluation, things to just, be careful about with these drugs. So we have our first line options here at the top: Bupropion, nicotine replacement, Varenicline, and then our alternative options, clonidine and nortriptyline. And what are some of the things that kind of need to be watched, right? So blood pressure and heart rate are definitely going to be a greater concern with bupropion with its norepinephrine effect. Nicotine, we know it's going to be the same effect as someone using nicotine. And then clonidine is going to obviously could lower both the pulse and the blood pressure while they're on it. If they stop it abruptly, then they get the rebound hypertension. And then nortriptyline has that effect on norepinephrine as well, so it can slightly raise it. Renal function, liver function, really going to have to do with more metabolism issues and just clearance. All right, weight, bupropion can cause some weight loss, so does nicotine as well. Nortriptyline might cause a little bit of weight gain just because of its a little bit of sedation. And then we have those neuropsychiatric concerns that show up with Varenicline. Bupropion is used, again, for depression. It's used for smoking cessation. So we just need to keep that in mind. Nortriptyline is again, can be used for depression as well, pain syndromes. We do need to be cognizant of their cholinergic effects, anticholinergic effects of that drug in our older patient population. And then you may need to obviously consider other things. So product specific, with the nortriptyline, you may need to get a baseline 12 EKG. Make sure their electrolytes are normal, okay? Because hypokalemia, hypocalcemia, hypomagnesemia, and hyponatremia that's severe can cause QRS widening, QT prolongation. So just keep those things in mind. Now, bupropion can also cause a false positive on a urine drug screen for amphetamines because of its metabolite. So just keep these subtle things in mind. Now let's step into the nicotine replacement therapies. I mentioned earlier that we do have a number of options. So let's first talk about some of the warnings, because we just talked in general about some of the key side effects. But nicotine replacement therapy being one of our first line options, one of our recommended options, one of the ones that we would use potentially in pregnancy, has some issues. One is you've got to stop smoking with the initiation. Okay, that is a key recommendation, counseling point for our patients. The next would be patients with cardiovascular disease. Now, we can use it in cardiovascular disease because they're going to smoke anyway, but we want to be careful with the dosing, and we're going to talk about dosing here in a second. I'm going to show you how to do some of that. We've got a table that summarizes that for you. Try to make it a little easier, but you don't want to ignore this, especially in the patient who is an acute cardiac patient or post-MI patient scenario where they're having cardiac dysrhythmias. Because if we overdose, use the wrong dosage form, the wrong amount, then we can see that nicotinic toxicity. Nicotine can increase some of the acid production that could potentially worsen peptic ulcer disease and GERD, and then decrease clearance with renal and hepatic. When you look at then the formulation here in the middle, you see we have gum, the lozenge, and then patches and nasal spray. There are formulation-specific warnings that are warranted to consider. Like, you don't want to chew the gum like you chew bubble gum and just keep putting bubble gum in your mouth and piece after piece after piece after piece. You need to give some space. I mean, it does say the maximum number of pieces in a day is 24. That would theoretically be one an hour all day long. But typically what you have them do is take one, and they can repeat a second dose if they're still having some cravings. But they need to really try to avoid the excessive back-to-back use. While there is a max and it allows you to go up that high, it's not necessarily recommended to do that. Now, there's also the administration of how you do it. You don't sit there and chew it, blow bubbles, all these things. You kind of chew on a little bit and you park it. and it slowly releases some of that nicotine. So careful how you use it. Now the lozenge, that's the same truth, the lozenge. You don't want to use more than one at a time. There is a max of 20 per day. Now both of these formulations do have sodium in there. So if you have a patient with cardiovascular disease and known heart failure, or you have fluid volume issues, this could be a potential problem. So just keep that in mind. The other for the gum and the lozenge have to do with the name. So Nicorette gum sounds like Nordet, the birth control pill. Again, Nicorette comes as a lozenge as well. So just look-alike, sound-alike drug name issues. We don't want to make a mistake. I don't think birth control is going to help you stop smoking. The patch. It does contain metal, so you need to take it off if you have to go to get an MRI. It's known as Nicoderm, and so we don't want to dispense Nitroderm, which is nitroglycerin. That will definitely change your blood pressure and your pulse. Nasal sprays have to do with the number of doses, and then it's typically 1 to 2 sprays in the nostril per hour. So 3 months total treatment is really the max effective dose. You really shouldn't be using it that much longer. For sure, definitely not going past 6 months. Patients who have chronic sinusitis, allergies, allergic rhinitis typically don't do as well with this. I mean, I don't see how people tolerate that much spraying up their nose. But maybe they like it. I don't know. All right, so let's go back to a little bit of trivia. Since we've been talking about dosage formulations, there used to be an inhaler on the market. Why was the nicotine inhaler discontinued? Well, it was taken off the market back in 2023 due not to a safety problem, not even due to a tolerability issue. It was due to the essential resin that they put in the mouthpiece of the inhaler, and they just could not keep up with the supply, so they just decided to stop. All right. Now let's dive a little bit back into the dose. You heard me talk about that at the beginning. We talked about the number of cigarettes in a pack, calculating a history correctly, thinking about their comorbidities, picking the right drug. If you're going to use nicotine, they have to stop smoking on their quit date, and this is the day you start to use this. Well, it's governed around the amount of cigarettes that you smoke. Okay, so this is again a complete table, kind of hard to see on the video, so I'm going to zoom in on the sections. But again, this table is available for you at thisiswhy.health in its entirety. Because I think it's important to learn, or I think it's easier to study when you can look at things side by side, and instead of jumping all around from table to table or whatever. Some people don't even like tables. I mean, again, this is just put together for those of you who do. Typically, people request these from us. They've historically liked them, so I'm providing them there for you if that's helpful to you. So for gum, you can see that it's based on the number of cigarettes. So 25 or more is sort of that cutoff of the milligrams that you're going to use. So more means more nicotine. That's not rocket science. Again, we talked about the number of pieces per day, 24. Try to minimize them per hour if you can avoid the back-to-back-to-back. There is a titration that you can go through and some taper. So weeks 1 through 6, you're going to have to use a little bit more, and then you start spacing it out as you go on. Because the goal by 12 weeks, that is the typical duration of treatment where we see abstinence, were markers, and that's indicated especially in the evidence of where you either succeeded or you didn't, right? Now with gum, remember I said you're not going to enjoy it like bubble gum and blow bubbles and have a good old time with it. It does have a little bit of a minty, peppery taste, and so you chew on it for a little bit slowly, and then you park it. And you park it back into the buccal mucosa, and you just let it slowly kind of leak out. And the more you chew, you're releasing more. And then, of course, you don't want to eat or drink 15 minutes before or while using the gum that's parked, because that could facilitate the change in the kinetics and the release. Now, as it relates to the lozenge, okay, again, you base it on the number of cigarettes, but you smoke your first, cigarette within 30 minutes of waking, then you're gonna, that's a high amount of usually nicotine craving. So we start out with, a 4 milligram lozenge, and then if you can go longer than 30 minutes, then you're probably okay and not going through withdrawals, so you don't need as much. And so it's the time for when you need your first smoke in the morning. Okay, so again, we have that maximum amount. We don't want to chew or swallow it. We want it to allow it to park there in the buccal mucosa, and then slowly alternate sides and also avoid certain drinks and stuff while you're using the lozenge. Now, moving on to the nasal spray. Again, the dose. So when we look at doses that you can use, it's based on 1 to 2 sprays per nostril per hour. Okay. Now, you do need to prime this device first, especially if you're not using it for more than 48 to 24 hours. You need to prime it. You blow your nose. Okay, clear everything out, because you don't want to blow your nose right after using it. You could blow some of it out. You kind of tilt your head back a little bit. You point the tip into the nostril, usually kind of angle back. And you're not going to sniff it in and go through all this emotion. You're just going to spray it, breathe through your mouth, and allow it to minister. You wait 2 or 3 minutes before, needing to blow your nose. Okay, if you're not getting to 8 doses a day, you're probably not going to be effective. So you need a certain amount, and so you got to be able to tolerate that. That's a lot of sprays in a day in the nose, and then going back to back to back. I don't know. The patch, again, is based on the number of cigarettes per day. We have a 21 microgram, and then we have a 14 microgram based on 10 cigarettes per day. So that's half a pack. Okay. Apply to a clean, dry area, no abrasions, no injury to this tissue that could influence the absorption. We'd try to wear it for 24 hours, rotate the site. Okay, and then you discard, you fold it together, and you throw it in the trash so that it can't be, consumed or leaked out. There is a taper effect that you can utilize to, again, wean you off here. That's good for you to kind of be familiar with. Okay, so all first-line treatments are used for at least 12 weeks. Okay, so picking one of these treatments, first line, in order to help reduce the risk of relapse and to encourage abstinence while minimizing unnecessary side effects. Now, if you're using nicotine replacement therapy, that dose is, again, based on the dosage formulation you've chosen. You saw that. The number of cigarettes you smoke, okay? And so we need to watch for potential toxicity, especially cardiovascular-related toxicity. Special populations, pediatric patients, bupropion has been used. I just got to be careful. During pregnancy, lactation, again, non-pharmacologic treatments would be preferred if possible, but nicotine replacement therapy can be done with close monitoring. Again, they're going to smoke anyway if you don't. Geriatric patients, again, we typically avoid drugs that are going to have anticholinergic properties. That would be like nortriptyline. Nortriptyline can also be associated with some hyponatremia, so we try to stay away from some of those, okay? All right, so when we better understand why we do what we do in medical practice, we are more equipped to explain things to the patients that we have the privilege to serve. Well, why does that matter? Well, in this topic review, our goal is to get them to stop smoking. And so we need to create shared decision-making, patient empowerment, and improve adherence to these treatments. And we can best do that when we understand why and how we're using them. So we need to be able to communicate that to our patients. These and other topics are available at thisiswhy.health, so please check it out. But in summary, the first line options are, we have three. We have that Bupropion, nicotine replacement therapy, Varenicline, especially when combined with cognitive behavioral therapy, we can see clinically relevant abstinence rates. Okay, and this can help improve some of those long-term outcomes that are negative for patients and all those organ systems that we talked about. But we got to pick the right agent for the right patient, and within that, we have to use the right dose, especially in the context of treating nicotine replacement or abuse, may be different than obviously for some of the other conditions. So, hope you found this to be helpful, and we'll see you next time on This Is Why. Take care.